Thank you for the introduction. These are my disclosures. The 2015 guidelines for Peyronie's disease from the AUA, which we still use now in 2024, are very good at giving a pretty robust sentiment on history, physical examination, but importantly, there are very important recommendations on penile goniometry in the established intracavernosal injection induced erection, as well as penile duplex ultrasound to evaluate plaque character and shadowing and other characteristics. There's a pretty strong evidentiary firmament to this. As early as 20 years ago, Dr. Levine and Dr. Greenfield established a standardized patient evaluation, importantly describing penile ultrasound, penile goniometry, but also that last sentence of the paragraph is particularly important, suggesting that photography performed either by the technician or by the patient is actually inferior and doesn't provide a consistent result on angulation and deformity. And this evidentiary basis has been expanded over the last couple of decades with multiple publications by colleagues in this room, including Dr. Mulhall and his group. And this is one such paper showing the superiority of induced erection and goniometry. You can see here that they looked at photography versus vacuum-assisted erection versus the gold standard of penile injection and found that there's a significant, substantial underestimation of penile curvature compared to the gold standard when you use photography or vacuum device. And so it's pretty clear that everybody in this room that practices Peyronie's disease evaluation uses goniometry in some fashion, and this is an example of that. But there are some deficiencies, and in particular, it's imprecise. So this is a paper by our esteemed colleague here, Dr. Ziegelman, to my left, showing that there can be quite a bit of variability, even intra-observer variability as well as inter-observer variability on the measurement of a curvature. You can have essentially a 20-degree swing in the measurement depending on how you draw the lines on your example patient. And this is important not just for clinical outcomes tracking and research outcomes tracking, but also for commercial insurance and practicalities of getting a patient in to get intralesional collagenase or surgery. So it's important that we identify ways that we can do this better. Dr. Walsh and colleagues out of the University of Washington developed the UW-Penn app. This app involves coaching the patient to take a photograph of their penis. The penis is then pixelated and de-identified, and then the patient is coached on where to place some lines to measure angulation as well as girth deformities. Importantly, the patients love this compared to coming in for a penile injection and goniometry, but the curvature measurements did underestimate the curvature compared to gold standard intracavernosal injection and goniometry. So what can we learn from our orthopedic colleagues? If you show a urologist a picture of a scoliosis and say, hey, what's the angle on this? They'll draw a couple of lines, much like we do for a Peyronie's evaluation, but that's actually not what our orthopedic colleagues do. Our orthopedic colleagues calculate something called the Cobb's angle. To get the Cobb's angle, they look at the most inflected vertebrae at the top and bottom of the curvature, and then they draw two intersecting lines and measure that angle called Cobb's angle. Now, this can be somewhat difficult, as you can imagine, if you're looking at an x-ray. And so what they do is make it even more difficult by drawing a couple of perpendicular lines to the lines that are intersecting and create a quadrilateral. Solving with simple geometry, you can see that Cobb's angle is preserved a little bit closer to where the angulation is. And again, important because if you were to draw the lines to intersect in this picture, the lines would end up off the screen somewhere over here or over there, depending on where you're sitting in the room. And so by using that quadrilateral approach, you can evaluate the Cobb's angle a little bit more accurately. Colleagues at Shanghai Jiao Tong University, a group led by Shang-Chen Li, described using this for penile deformities, in particular for hypospadias and Cordy. So they segment the penis into vertebrae, if you will, and calculate a Cobb's angle. On the left of this slide, you can see the classical goniometric approach that we use in the clinic, and in the middle here, you see how they can define the vertebrae by drawing a rectangle sort of distally, subcoronally, as well as at the root of the penis, close to the pubic symphysis, and then calculate a Cobb's angle, which most easily can be done by intersecting those lines. And that gives a more consistent, reproducible curvature and assessment. And this can also be fed into different computer or computational models, for example, using an app, taking a two-dimensional picture, segmenting it using AI, and you can do this very easily. The other problem with goniometry is that it's agnostic to volumetric deformity. So it fails to capture hourglass, indentation, any volume loss. So many different groups have proposed using some form of a 3D photographic evaluation. One of them is called 3D photogrammetry. This is a representation of what that might look like. So this is an array of cameras, hundreds of cameras that then are stitched together to create a 3D representation. In 2021, a group from Italy led by Dr. Pavone did this with 45 images of a penis and stitched those things together. This was not with 45 different cameras. This was one camera that was carefully rotated around the patient. And they came up with a 3D manipulable model that they could then rotate for the patient in the office. You can see in picture on the right upper picture and the bottom left picture that they can simulate what surgery might look like and what the outcome might look like. So this was very beneficial for patient counseling. In a similar vein, there's something called 3D structured light scanning. At the bottom, you can see an iPad with a structured light scanner attached to it. This was from a group out of Colombia led by Dr. Margolin and Dr. Stahl. And you can see on the top row, those are 3D printed deformities, which are then scanned using that device on the iPad, and they were able to calculate volume loss for the first time digitally. And so that was a useful technique that we then took at UCLA and invested in this device and started a clinical trial. So since 2019, we've been enrolling patients on an IRB-approved protocol to have them get three-dimensional representations of their penises for patient counseling and tracking of outcomes. And you can see one example of a 3D reconstruction that we can show the patient in the clinic office and rotate the penis and show them what surgery or Xiaflex or something else might look like for them. And you can imagine every guy you introduce this concept to is eager to be consented for this project. Morphometry can be done on these 3D representations. So this is, you can take these objects, you can wireframe them, take them into a simple sort of three-dimensional tool, an online tool or computational tool. This was a paper validated by Dr. Walker, who's in the audience. I spy him over there. He's a resident at Colorado now, but when he was a medical student, he developed the workflow that we still use to this day. And these are just some examples of 3D reconstructions and morphometry. So right now, what we're doing with this project at UCLA is that we're taking these 3D pictures and then we're taking them again after a patient has gone through a round of Xiaflex or has gotten penile surgery or an IPP, and we're looking at these volume losses, these angulations, and that sort of thing. So there are some limitations. Accuracy and precision with goniometry remain elusive, especially with volume loss and volume deformities. 3D reconstruction can help, but these workflows are quite time-consuming. The pictures that I showed and the reconstructions we do at UCLA take over an hour to do on the computer, but AI integration might augment these workflows, so stay tuned. But honestly, clinic goniometry and duplex ultrasound are still here to stay. Thank you very much.